Hello everyone, this is Pathology MOOC 2, Part 2. You have a case. Please read the case in front of you.
Okay, a 32-year-old woman presented to the clinic with a complaint of diarrhea for the past 3 months. She stated her diarrhea has been watery and not greasy, and she has not seen any blood in the toilet bowl. Upon further questioning, she stated that she has also experienced wheezing and skin peeling on her hands and feet. On physical examination, the patient's face and neck appears as in the image.
I'm going to ask you questions regarding this case and outside the case. What is the definition of an abscess?
The abscess is a localized collection of pus, which may be caused by seeding of pyogenic organisms into tissues or due to secondary infection from the necrotic foci.
So, focal collection of pus caused by seeding of pyogenic organisms into a tissue or by secondary infection of necrotic foci. What is the structure of an abscess?
Abscess has a central, largely necrotic region, which is surrounded by a ring of preserved neutrophils, and then a zone of dilated vessels and fibrous proliferation, which indicate the attempted repair.
Okay, so this is actually the definition of an abscess. Okay, and how neutrophils migrate to the site of inflammation?
So firstly, the neutrophils rose, and then it began elevated, and then it adhered to the endothelium, and then it transmigrated the endothelium, and it pierced the basement membrane, and then migrate to the chemoattractants, which is released by the injured cell.
So rolling, activation, adherence, then transmigration across the endothelium, and traversing the basement membrane, pass into the gaps, migration by chemotactants or chemoattractants to the site of injury.
Yes, sir.
What blood tests to identify any inflammation?
So we can do a full blood count in which there will be elevated WBC and also ESR and then CRP.
CRP, okay. And what is the definition of acute phase reactants?
So these are substances that are released during the period of acute inflammatory reactions in the body.
Can you give me example of acute phase reactants?
CRP and then procalcitonin, ferritin, and so is that all I remember? So.
Okay, like what are acute phase reactants, do you know? So first, they are inflammatory markers that they will show significant change in serum concentration during inflammation. That's it. And they are also produced by the liver during acute or chronic inflammatory states.
Yes.
And interleukin-6 is a primary cytokine responsible for inducing the production in the liver. Also, interleukin-1 and T tumor necrosis factor alpha. So we have two types of acute phase reactants, positive and negative. Positive phase reactants are upregulated and their concentration increased during inflammation. Negative acute phase reactants are downregulated and the concentration decrease during the inflammation. CRP, ferritin, fibrinogen, and serum amyloid A, they are positive phase reactants, acute phase reactants. Negative, like albumin, transferrin, and antithrombin. These called negative acute phase reactants, nothing more. So 3 lines, you answered the question. Okay?
Yes, please, sir.
What is the definition of carcinoid then?
So it is a slow-growing type of tumor, which is arise from the. It is a slow-growing type of neuroendocrine tumor, which arises from the cells of neuroendocrine system.
Okay, so the definition, as you just told us, it is a slowly growing type of neuroendocrine tumor originating in the cells of neuroendocrine system. Okay, what is the most, where it is most commonly found?
So it is most commonly found in the
90 to 95% in the small intestine, ileum and the appendix, but can found other places like rectum, stomach, lung. What is the most common secondary site of metastasis?
so liver, sir.
Liver. And
Yes.
when it metastasizes to the liver, what is called then after?
So, sorry, sir.
Carcinoid syndrome. Carcinoid syndrome. When it is the carcinoid tumor, when it metastasizes to the liver, it is called carcinoid syndrome.
Yes, sir.
What is the cell of origin?
So from the enterochromaffin cells, EC cells.
Enterochromaffin cell and called Kolchitsky cells in the crypts of Leberkon. Okay?
Yes, sir.
So Leberkon crypts, Kolchitsky cell, Kolchitsky cells. What does it release, the carcinoid tumor?
So the tumor releases a significant amount of serotonin and also prostaglandin, bradykinin, substance B, and histamine.
So most probably is serotonin, 5-hydroxytryptamine, bradykinins, prostaglandins, cyclic-kinins, substance B, and histamine. What is the clinical presentation of carcinoid tumor?
So the patient can present with abdominal pain, and then the patient will have the features of carcinoid syndrome because of vasodilatation and bronchoconstriction. In respiratory system, the patient will have wheezing or asthma-like syndrome because of bronchoconstriction, and because of vasodilatation, the patient will have cutaneous flexion and also diarrhea, malabsorption, and in cardiovascular system, the patient will have valvular head lesions and also endocardial fibrosis.
Okay, so simply periodic abdominal pain or a syndrome. So the tumor itself, you can have occasional abdo pain, but the syndrome, you have cutaneous flushing, diarrhea, malabsorption, and what is called cardiac carcinoid syndrome, which is right-sided most commonly, especially the tricuspid valve with fibrosis of the endocardium, or pulmonary manifestations like wheezes or asthma-like syndrome due to bronchial constriction by the 5-hydroxytryptamine and other substances.
Yes, sir.
Okay, what is carcinoid heart disease?
So it is a cardiac manifestation due to a primary carcinoid tumor from the distant side. So actually, sir, I don't know, sir.
So as we said, it is right-sided heart.
Yes, sir.
Right-sided heart affection due to substance affection on the heart, like the same substances, serotonin, bradykinin, substance B, tachykinins, these substances will badly affect the right side of the heart, especially the tricuspid valve, and can cause pulmonary, systolic, and diastolic heart murmurs. Okay, so due to cardiac involvement, primary occur in the right side of the heart, tricuspid valve most commonly affected. This is simply carcinoid heart disease in one line. Don't say, I don't know. Especially in MRCS, OSCE, you should start the answer. If you feel that you will not be able to answer it at the time of the examiner question, don't tell postpone, because this will make you busy.
Yes, sir.
Will make you busy and will make you stressed out throughout the whole exam. So try to give the reasonable answer as a surgeon. So carcinoid heart disease, it is heart affection by the carcinoid. Okay, so you told him the same, but in another synonym. Due to what? Due to right-sided heart affection or pulmonary murmurs, nothing more. He can give you half the answer. Don't try to postpone a lot. If you feel you are stressed out during one question and you know it already, okay, leave it for the end. You know it, you are going to pick it mark. But if you don't know it, just try to answer and don't express your ignorance, okay?
Yes, sir. Okay.
If it is a critical care scenario, you can clearly tell him, I will talk to my senior, I don't know. This is very tricky and very nice question. Answer in the critical care. You are safe, doctor, instead of saying, oh, I will stop here, I don't know. No, talk to your senior. Is that an answer? Yes. This is an answer, give you at least half of the mark, okay?
Yes, sir.
How does the carcinoid spread?
So because it produces a large amount of beta-catenin gene that enables the tumor cell adhesion in the distant site, thus by promoting the metastasis.
Okay, so cells produce significant amount of beta-catenin, which enable the tumor adhesion and thus the metastasis. Okay, so these beta-catenins produced by the tumor will lead to more tumor cell adhesion and promoting the metastasis process. Why a person with heavy metastasis in the liver has symptoms than with primary tumor? It is easy question.
Yes, sir. Because most of the blood from the GI tract must pass through the liver before it reaches the systemic circulation. And the liver has strong enzymes that can break down and utilize the excess serotonin and other products released by the tumor. So when the liver has been metastasized and the liver cannot function normally, the excess product from the primary tumor can reach to the systemic circulation easily. So the patient will get the symptoms of the carcinoid syndrome. Yes.
So if it is a carcinoid syndrome, sir, the liver itself is able to degrade the substances of the tumor, so preventing them from going to the circulation. But if the liver itself affected by metastasis, then it will be obscured and hindered to metabolize these 5-hydroxytryptamine and these substances of the carcinoid tumor. Then it will bypass and it will go to the systemic circulation, leading to systemic manifestations of a syndrome of metastasis. Okay, what is the diagnosis? How you diagnose a carcinoid syndrome?
So we can do the blood test to identify the chromogranin A, and then our urine test to identify the 5-HIAA, and then for immunohistochemistry to identify the chromogranin B.
So because it's 5-hydroxytryptamine tryptamine, so you will go to collect 24-hour urine for testing the 5-hydroxytryptamine. This is one of the best initial tests with the chromogranin A in the blood. So serum chromogranin A, urine 5-HIAA, and also immunohistochemistry staining positive for chromogranin B. These are the diagnosis in simple.
Yes.
What is the imaging used to diagnose? We missed the imaging in the diagnosis. So what is the imaging?
So we can do abdominal X-ray, and then we can also use the CT scan.
So it is CT scan, octreotide scan, nothing more. So to localize the primary tumor and assess the extent of the tumor and its metastasis, CT scan. To localize the primary tumor site or its recurrence, it is octreotide scan. What is the treatment of carcinoid syndrome? So surgical resection of the tumor.
Yes.
From appendicectomy, or if it is more than 1.5 centimeter, then right hemicolectomy. Okay, so
Yes,
again, surgical resection. And also what else?
Okay, so apart from surgical therapy, apart from surgical treatment, we can also give medical therapy, such as the octreotide.
So simply somatostatin analog, octreotide. Okay,
Yes,
and this is to alleviate the systemic manifestations like flushing and diarrhea. Or surgical resection, and I put you 2 plans. Appendicular carcinoid treated by appendicectomy if it is localized to the tip of the appendix and less than 1 centimeter. Or right hemicolectomy with regional lymphadenectomy if it is the tumor breaches the serosal surface, invades more than 3 millimeter of the appendix, or more than 3 centimeter diameter.
yes, sir.
Okay.
So can I
Another case?
So can I ask a question, sir?
Yes, of course.
Yes, sir. Okay. If the tumor is at the base of the appendix, or the lesion is just like 2 centimeter, so what will we do, sir?
What?
So if the tumor is at the base of the appendix, or if the lesion is more than 2 centimeter in size, so what will we do, sir?
I post it to the group. Look at the group. I post it to the group. So if it is appendicular carcinoid, with the syndrome, you need systemic octreotide, systemic somatostatin analogs. And for the tumor, it is surgical resection. Okay.
Okay, sir. Okay, sir. I see, sir. Okay.
Again, you can ask your question again. Your question again. Until I found someone raising his hand. From the 10 or 15 candidates, please raise your hand. Ron, Shahadat, Tom. Okay, what's your answer again? What's your question again? Sorry.
So my question is, if the tumor is not at the tip of the appendix, it is at the base of the appendix.
Yeah. I posted to the group as well. You should have a surgical resection margin. So if it is the tip and limited to the appendix, you can remove the appendix with the tumor with safety. But if it is at the base and you are not going to remove the cecum with the appendix, so it is right hemicolectomy then. Okay.
Okay, sir. Okay.
Yeah, it is very clear. Again, if it is located at the base of the appendix, or even if it is resected with positive margins after you resect it, because you will send it to pathology, then you need to do completion right hemicolectomy. You know that, because otherwise it is recurrent. So you haven't treated the carcinoid, and what are the complications are going to happen right-sided heart disease, which is so severe complication for a like 40 or 50-year-old gentleman or female. Okay, thank you. Hetero, thank you, Anista.
Yes, sir.
Okay, Hetero, you can read the case. Station
A
2.
A 56-year-old man presents to his primary healthcare physician with abdominal pain. His abdominal pain is in the epigastrium and has been persistent. He has had episodes of night sweats and has unintentionally lost 20 pounds over the course of 3 months. He has a past medical history of H. pylori infection and obesity. Physical examination is notable for epigastric abdominal tenderness upon palpation. An upper endoscopy demonstrates an invasive ulcerative lesion of the stomach. I'm done.
Okay, I'm going to ask you specific questions regarding what is gastrointestinal tumors? GIST. What is GISTs?
They are stromal tumors originating from the interstitial cells of Kajal, commonly originates from the stomach, but can occur in any other part of the gastrointestinal tract. Can also be seen rarely in organs such as the pancreas, apart from the gastrointestinal tract.
Okay, so apparently GIST result from mutation of the growth factor receptor gene, c-KIT. Some are caused by previous radiation therapy or to the abdomen and for other organs. And the completion of your common sites, again, the tumors are slowly growing and malignant potential vary from minimal to significant. And about 70% occur in the stomach, and the rest can occur in the small bowel, others esophagus, colon, rectum. The average age is 50 to 60. Okay.
Thank you.
What are the symptoms of GIST, gastrointestinal stromal tumors? What is the symptoms?
Patient may
According to
present.
the location.
Yeah.
So it is a tumor. What is the tumor?
A mass in which the growth is uncontrolled.
So mass is not a symptom. Mass will cause obstruction, dyspepsia, or it bleeds. That's it.
Yeah.
I don't know. I don't need just this line was satisfactory to the examiner. Okay. What is? How can you diagnose the GIST?
Imaging studies, a CT scan, an MRI can be used. Endoscopy, endoscopy.
Exactly. Endoscopy biopsy and endoscopic ultrasound for staging. Again, endoscopy biopsy and endoscopic ultrasound for staging. Okay. What cancers are linked to H. pylori? The Helicobacter.
Adenocarcinoma. Yeah, adenocarcinoma of the stomach, lymphomas, that's the multi-associated lymphoid tissues, lymphomas.
So 1% gastric adenocarcinoma and less than 1% maltoma. Okay, yeah. What is maltoma? What is maltoma?
There are tumors arising from mucosa-associated lymphoid tissues, within the mucosa of the gastrointestinal tract. It's a rare type of non-Hodgkin lymphoma.
So you need two words, non-Hodgkin and B lymphocytes. So it is a B cell type non-Hodgkin lymphoma of the stomach.
Okay. Yeah.
What is the treatment of GIST?
Surgical and then adjuvant therapy, surgical with surgery, complete removal, and then biologic agents, imatinib, can be used, targeted therapy.
This is what I'm going. If in your exam, just answer. If you have very nice information, then you can like, you know, don't show everything with you. What is the rule
Okay.
of biological agents? Imatinib
Imatinib.
and its mode of action.
A tyrosine kinase inhibitor, tyrosine kinase receptor inhibitor,
And what is the
antagonist.
rule of this imatinib?
Yeah,
What is the rule of it?
it inhibits tyrosine kinase receptor.
So when the tumors are positive for, this is what's been asked in the exam. When the tumors are positive for KIT protein CD117, CD117 positive, okay, c-KIT protein CD117 positive, then you can use a tyrosine kinase inhibitor. It is effective for patients for unresectable and metastatic malignant GISTs. Again, imatinib is a tyrosine kinase inhibitor, imatinib, used when a tumor is positive for CD17 c-KIT protein positive, and it is effective especially in unresectable and metastatic malignant GISTs. Also can be adjuvant in after resection. So it is adjuvant, not new adjuvant, it is after. So it is adjuvant after resection in adults. And if it is refractory to imatinib, what is you are going to use? Other new biological agents like sunitinib and regorafenib. Regorafenib or sunitinib. So imatinib, suni, if it's refractory, use the suni one, and rigora as well. Okay.
Yeah, thanks.
Thank you so much. This is the end of 2 stations, and the exam will be like this. If you know the answer, it is yes or no. Okay. It is not something that I could make it secret. It is yes or no. So it's one sentence. If you know it, you will answer it. If you don't, then you missed the whole station. And by the way, some answers to the question linked by the following questions. So keep going, keep studying. Don't, because GIST was a new station. I added the station, but again, it cannot be present in any upcoming exam. You can have Multoma full station or whatever. So you will have new detailed stations and other stations from the notes, not present in any other book, but will not fail you. Thank you so much. Keep going. Inshallah with you till the end. Good luck.